Hey everyone, and welcome. In this crash course, we are diving deep into the must-know medications for the skin. These are the drugs you're definitely going to see on your exams and, more importantly, in your clinical practice. So let's get right into it.
So think about it for a second. Rashes, burns, acne, skin problems are everywhere, right? But what separates a good nurse from a great nurse is really understanding the why. Why this cream for this rash? Why this pill for this condition? That's what we're going to connect the dots on today.
First up, let's talk about inflammation. You know, the stuff that makes us red, swollen, and oh so itchy? We're looking at things like dermatitis or that awful poison ivy you got last summer. The main goal here is simple: calm the skin down. And our number one tool for that? Glucocorticoids.
So how do these topical steroids work their magic? Well, it's a three-pronged attack. First, they're anti-inflammatory, which directly fights that redness and swelling. Second, they're antipyretic, which is just a fancy medical term for anti-itch. And let's be honest, that's the part we all care about most, right? And third, they're vasoconstrictive. They actually cause the little blood vessels in the skin to tighten up, which helps reduce swelling even more. Three powerful actions, one very happy patient.
Okay, this is a huge safety point, so listen up. Just because you're putting it on the skin doesn't mean it stays on the skin. These drugs can get absorbed into your bloodstream. And here's the kicker: not all skin absorbs equally. Thin, delicate skin, like on the scalp, face, and armpits, soaks this stuff up like a sponge. But thick skin, like the palms of your hands or the soles of your feet, not so much. This is a classic NCLEX question, so you have to know these high absorption areas.
All right, let's switch gears from those acute itchy rashes to more chronic conditions. We're talking about things that need a long-term game plan, specifically psoriasis and the damage caused by the sun.
Treating psoriasis isn't just a one-and-done kind of thing. You've got to think of it like climbing a pyramid. For milder cases, you start at the bottom with topical treatments you put right on the skin. If that doesn't do the trick, you move up a level to systemic meds, which are pills or injections that work throughout the whole body. And then, for the most severe cases, you reach the top of the pyramid, the biologics. These are super-targeted drugs that go after specific parts of the immune system.
Now let's talk about sun damage. You might see a patient with something called actinic keratosis and think, oh, it's just a little rough patch of skin. But no, you have to see it as a warning sign, a big, flashing red light. Why? Because these little patches can, and often do, turn into squamous cell carcinoma, a type of skin cancer. So treating it isn't just about cosmetics, it is literally cancer prevention.
So, for conditions with that thick, scaly skin like psoriasis, we use something called a keratolytic. Salicylic acid is the star player here. Let's visualize what's happening. That outer layer of skin is held together by a kind of cellular glue. Salicylic acid comes in and dissolves that glue, causing the tough, scaly layer to soften and peel right off. But, just like with the steroids, it can be absorbed systemically. Too much can cause a condition called salicylism. And the absolute hallmark sign you need to know for your exam is tinnitus. That's ringing in the ears.
Okay, let's pivot to something almost everyone has dealt with at some point: acne. You know, the approach to treating acne is super logical. It's not random. It's a step-by-step fight that escalates depending on how bad the acne is.
And this ladder shows that progression perfectly. For mild acne, you start on the bottom rung with topical stuff, creams and gels. If things are a little more serious, you climb up to the moderate level, adding in oral antibiotics to fight the bacteria from the inside. But for that really severe, cystic acne that just won't quit, that's when you bring out the big gun at the very top of the ladder, isotretinoin.
Okay, everybody, stop what you're doing and focus on this. If there is one single thing you take away from this entire explainer, this is it. Isotretinoin is highly teratogenic. That means it is absolutely devastating to a developing fetus and can cause horrific birth defects. This is a non-negotiable 100% absolute contraindication for pregnancy.
The danger is so real, so severe, that there's a whole federal program for it called iPledge. This isn't optional. It's a strict, mandatory system that involves the patient, the doctor, and the pharmacist. Everyone has to be on the same page, with multiple monthly checks and confirmations to make absolutely certain that pregnancy is not a possibility while on this drug.
And beyond that massive pregnancy risk, there are other must-know facts for isotretinoin. First, it can spike your triglycerides, so you have to monitor blood work. Second, it's a vitamin A derivative, so patients must stop taking any vitamin A supplements to avoid toxicity. Third, you've got to watch for mood changes, specifically depression. And finally, it makes the skin incredibly sensitive to the sun, so sun protection is absolutely essential.
All right, we're making a big shift now into a very high acuity situation, burn care. When that skin barrier is gone, the #1 threat is infection. So the whole goal of these medications is to stop that local burn from becoming a deadly, body-wide infection known as sepsis.
In the world of burn care, there are two big names you absolutely have to know for your exams. They might seem similar, but they have critically different side effects. So let's put them side by side and break them down.
First up is silver sulfadiazine. Its main job, like we said, is to prevent sepsis. But here's the crucial thing you need to remember. Its major side effect is that it can cause leukopenia, which is a drop in the patient's white blood cell count. Think about how scary that is. The drug you're using to prevent infection can actually lower the body's own infection-fighting cells. So what's the nursing action? You're going to be watching that CBC, the complete blood count, like a hawk.
Now for its counterpart, methanate acetate. This one is really good at getting into that dead avascular tissue that doesn't have a blood supply. But its big, scary side effect is totally different, metabolic acidosis. So how are you going to spot that at the bedside? Let's think patho. When the blood becomes too acidic, the body's fastest way to compensate is to breathe faster, to blow off CO2. So if your burn patient starts hyperventilating, you need to be thinking metabolic acidosis. That's your clue.
You know, we've talked a lot about fixing skin that's already damaged, but let's wrap up with the single most important preventative medicine we have for the skin, and that is, of course, sunscreen. This is truly our first and best line of defense.
So what's the magic number? You'll see all sorts of SPFs out there, but the evidence shows that an SPF of at least 15 is the minimum, the absolute baseline for getting effective protection from harmful UV rays.
And here's the thing. Just owning sunscreen isn't enough. You got to use it correctly. It needs about 30 minutes to actually bind to your skin and start working, so plan ahead. It also wears off, so you have to reapply every 2 to 3 hours, and even more often if you've been swimming or sweating a lot. And please remember to teach your patients that the sun is at its absolute strongest between 10 in the morning and 4 in the afternoon.
So we've walked through all these powerful drugs for treating skin when things go wrong, but this last question is maybe the most important one. What's our best advice for our patients to help them get it right from the very beginning? Because as a nurse, as a healthcare provider, your power in prevention is just as important as your knowledge of the cure. Something to think about.